Good afternoon. Uh, Today I am discussing acute kidney injury, also called as AKI, and continuous renal replacement therapy, which is called as CRRT also. Um, and in this presentation, I am talking mainly about definition of AKI and grading of AKI. I will try to make a series of presentation regarding AKI and CRRT. The first part is definition and grading of AKI. So first, coming to the definition of acute kidney injury. So earlier we used to call it as acute renal failure or ARF, which has been almost replaced by AKI in practice, and we use unchangeably acute kidney injury, and it refers to abrupt decrease in kidney function resulting in the retention of urea and other nitrogenous waste product in the dysregulation of extracellular volume and electrolytes. And all current definition actually include creatinine and urine output as a criteria. For defining AKI, or in terms of defining any kidney injury, whether it's an acute kidney injury or it's a chronic renal disease, creatinine is the criteria. We use creatinine to uh, define the onset, but is it reliable criteria? That is a big question, and the question arises in two terms. One is in the biochemistry point of view, and in biochemistry point of view, and another is the clinical point of view. Biochemistry point of view, creatinine is a quite reliable molecule which can actually say that whether the kidney is functioning or not, because the excretion point of view, creatinine is filtered from the glomerulus and has got minimal reabsorption from the tubule. So, it is a quite an ideal agent biochemistry point of view, but we measure the creatinine in the blood, and that makes it a little bit complex, because the creatinine in the blood remains normal up till a stage where there is a significant damage to the kidney. So there is a problem of delayed rise in the creatinine, in terms of the renal damage, and significant. When I'm saying significant nephron damage, it goes around 50% or more than that actually, and it depends on the age of the patient also, and the possible compensation of the nephron. But again, it's a quite delayed sign of renal failure. uh, Another thing which is we have to consider that the serum creatinine doesn't only depend on the excretion of the creatinine, it also depend on the rate of production, and that depends on the muscle mass of the patient or person. So if the patient is lean and thin, have lesser muscle mass, you will find that creatinine is less. So creatinine rises less in terms of renal damage. So it is a quite reliable biochemistry, but clinically we have to see other thing also. If somebody is not producing urine but they don't have a muscle mass, probably will not find a rise in creatinine adequate. So we have to take the creatinine as a criteria, but you have to think other thing along with that. So is there any other marker which can detect onset of AKI better than the creatinine? And they have came with probably quite a number of biomarkers with the research, which can detect how many, means whether there is when there is an onset of AKI, the patient has developed AKI or not, because we want to detect it early so that we can intervene earlier. So the two thing which I think is has been studied, two molecules which has been studied very in detail, is one is the NGAL, that is neutrophil gelatinase associated lipoclean, and kidney injury molecule 1. And for the NGAL, they have found that there is early rise of NGAL in comparison to creatinine for the onset of AKI. Um, Clinical significance of rise of NGAL uh, in a specificity point is a little you have to take a little cautious, be a little cautious, because NGAL can rise in some of the non-renal condition also. But definitely they have found that NGAL rises earlier than that. We can use it as a marker. Uh, Still, people are doing some research on the reliability, sensitivity, specificity of NGAL. The other molecules like interleukins and FAP, TIMP2, and calprotectin, these all are research biomarkers, still not available in the clinical practice, except probably NGAL, which which is being used at the moment, but still needing further study for the specificity point of view. Um, when we are coming to the diagnosis of AKI, again we have to rely mainly on the creatinine and urine output, as I have discussed earlier. Uh, and so at the moment we are following definition of AKI, or diagnostic criteria of AKI, given by group called KDIGO, or KDIGO group, and it defines AKI when there is a rise in creatinine by zero point 0.3 milligram per deciliter, or more than 26.5 micromole per liter within 48 hours, or there is increase in serum creatinine to more than 1.5 times, 1.5 times baseline, which is known or presumed to have occurred within prior 7 days. So the onset should be around within 7 days, and there should be decrease in urine volume to less than 0.5 mLs per kg per hour for 6 hours. So there are you can say three criterias. One is increase in creatinine by number 26.5 micromole per liter within 48 hours from baseline, increase in serum creatinine to 1.5 times from the baseline, or urine output less than 0.5 mils per kg per hour for 6 hours. After definition, next thing would be how to define the severity of acute kidney injury, and we say it is stages, because we assume AKI as a continuous process rather than grading, which is like different severity. But so because the severity usually progresses as disease progresses, that's why we define it as stages of the disease. And when we say staging of AKI, we go with history, and first time it has been defined in the literature by Rifle criteria with a group which is called ADQI group, in 2004. And actually they have defined renal damage rather than acute kidney injury or acute renal failure, and they have started from the risk, injury, failure, loss, and ESRD or end stage renal disease, by numbers, by criterias. And but if you will see the first first three stages are actually part of acute renal damage or AKI, and last two stages are actually chronic renal disease staging. So if you'll say they risk, injury, and failure, and that depends again on the increase in creatinine, you can say, to more than 1.5 times of baseline, or increase in creatinine more than 2 times, or increase in creatinine more than 3 times, depending on this. They have defined stages in and risk injury and failure. So 1.5 times, 2 times, and 3 times. And they have also defined in terms of urine output, and it is less than 0.5 ml per kg per hour for more than 6 hours, 0.5 ml per kg per hour for 12 hours, or less actually, when it's less than 0.5 ml per kg per hour for more than 12 hours. And it is if urine output is less than 0.3 ml per kg per hour for more than 24 hours, or you can say if the patient is totally anuric for more than 12 hours. So that is the base definition of, you can say, acute kidney injury, which has been carried out throughout the different definitions. I'm going to rifle criteria just to make the basis of staging of acute kidney injury, because it has been given initially. Later that definitions and staging has been modified, but mostly criterions remain same. For the other two staging, which is loss and end stage, are mainly subacute stages and chronic stages. So loss is called as persistent ARF if it prolong more than 4 weeks, and end stage renal disease is like chronic for more than 6 months, and patient is landing on anuria or acute, dependent on the long-term dialysis. Next staging and was given by Acute Kidney Injury Network Group, which is also called as Aiken classification, which was given in 2007, and it was published in Critical Care 2007 by Mehta et al. And if you will see, it carries the same classification, same staging, where you will find on the basis of serum creatinine, on the basis of urine output. And if you will see, urine output remains almost same, less than 0.5 ml per kg per hour, 6 to 12 hour, 0.5 ml, less than 0.5 ml per kg per hour for more than 12 hours, and then 0.3 ml per kg per hour for more than 24 hours, or anuria for 12 hours. So this is the same definition of initial 3 stages of rifle classification. But if you will see the definition for the serum creatinine, it just changed from the 1.5 times to 150% and 200%. So they have just converted into the percentage. So stage 1 is 150 to 200% rise from the baseline, and then 200 to 300 from the baseline, and more than 300 from the baseline, or patient is depending on dialysis, and rise of more than 3 milligram per deciliter remains same. So it is almost same definition, if you will say, which was given by Rifle, but they have just removed the L and E stages, because that is not definitely part of acute kidney injury. This is the group which has given this staging. Latest classification has which was given by KDIGO group, or called Kidney Disease Improving Global Outcome Group, and it has been published in 2009, and And you will see that they have just made it back to the from percent to 0.5, so 1.5 to 1.9 fold. And but the duration they have clearly defined, they have made it more clear, no less confusion. So if you will say urine excretion criteria remains same, there is nothing changed over time from the rifle. So rifle criteria for the urine excretion has been totally copied in Akin group and Kadigo group. There is nothing changed. So 0.5 ml per kg per hour, more than 6 hours, 0.5 ml per kg per hour for more than 12 hours, and then less than 0.3 ml per kg per hour for 24 hours, and anuria for 12 hours. So this definition remains same as it was earlier on in the rifle criteria and even Akin group. But coming to the serum creatinine concentration, that they just made it like more numerically visible or numerically clear. So it's 1.5 to 1.9 times or fold within 7 days, or rise of 0.3 ml per milligram per deciliter within 48 hours, and then going to 2 to 2.9 fold, and then more than 3 fold of serum creatinine. And they have also added few points like with an acute increase of 0.5 milligram per deciliter from if it is already more than 4 or equal to 4 milligram per deciliter. But for the exam point of view, if we can say, latest classification is from Kadigo group, and it on the urine excretion, it is the definition on the less than 0.5 ml per kg per hour for more than 6 hours, less than 0.5 ml per kg per hour for more than 12 hours, and less than 0.3 ml per kg per hour for more than 24 hours. And if you say for the serum creatinine concentration point of view, 1.5, remember like 1.5 to 2, 2 to 3, and more than 3. But for the purpose of examination or writing in the examination, you have to write it 1.5 to 1.9 fold in 7 days, 2 to 2.9 fold, and more than 3 fold from the baseline. For the UK point of view, we follow nice system of staging, and so it is nothing different. It's nothing different. It's just change in probably little bit in the unit, because in UK we follow micromole. So this is creatine rise by 26 micromole per liter within 48 hours, and but creatinine rise remains same 50 to 99%, but it also says 1.5 to 1.99 from baseline. And then urine output remains same, less than 0.5 ml per kg per hour for 6 hours. And then if you'll say the nice system for the stage 2, just forget about percent because it is easier to remember. Within 7 days from the baseline, 2 to 2.99 into baseline, and urine output criteria remains same for staging 2 from in all the staging. And stage 3 is within 7 days, 3 times or more from the baseline. It is quite complex if you want to remember everything, but I think just go for the creatinine rise for the stage 1, and then go for stage 1 like 1.5 to 1.99 from baseline and urine output definition. Then stage 2 same, stage 3 you remain same, just define 3 or more times from the baseline, or urine output goes down less than 0.3 ml per kg per hour for 24 hours, or anuric for 12 hours. So this is the same definition which is going through. You have to just remember the names, and names are coming from the rifle criteria, Akin classification, Akin staging, Kadigo staging. And if you you are facing some UK related thing, then you have to go from the in a nice system of staging. It's almost same. Just think what are the differences a little bit. So just to summarize here, rifle they have is staged in 5 stages. Stage 1 is so it's a risk, injury, failure, loss, and end stage. But the first three is acute kidney injury, and that classification almost remains same in Aiken group, kidney group, and then nice classification also. We are not discussing with loss and end stage renal disease because that is a part of chronic renal disease, not rather than acute kidney injury. This slide is for just showing the progression of acute kidney injury, and this is the last slide of the presentation. So here we actually mainly discuss how the acute kidney injury progresses and how we define the duration of the acute kidney injury in terms of acute and chronic. So if something is happening within 7 days and you have patient has developed acute kidney injury, that is called as acute kidney uh, injury by definition. If it remains up to 90 days from the onset and more than 7 days, it's called as AKD stage or subacute disease actually. If it is progressing slowly, but it is a stage where the chances of recovery of AKI will be there. But if somebody remains more in acute kidney injury and the patient has not reversed, then it is like if it is been more than 90 days, then we say it is already established CKD disease, and the progression after 90 days is means chances of recovery become quite less. So that is quite a good thing to define prognosis. And if you are discussing with the patient and or next of kin of the patient, then it's a good idea to define that in the terms of onset and because they usually ask you what are the chances of recovery from the renal failure. If somebody has landed on CRRT or something, then they will keep asking what are the chances. We can't define it in terms of the percentage or anything, but we can definitely say that if the patient has chances up to 90 days, or you can say when the established CKD is already more than 90 days, then before 90 days there will be higher chances than recovery after 90 days. This is just an arbitrary number, but this is the definition of CKD. If the AKI persists more than 90 days, it's which we defined as the CKD. Yeah, thank you for this listening this presentation that patiently. I will come with another part of a presentation on AKI and CRRT. Thank you very much.